So let's see. You can just see. Yeah, okay, bye. Thank you. So good evening, good morning, good afternoon to everybody. I welcome you to the International Federation of Kidney Foundation's World Kidney Alliance webinar today. And our IFKF-WKA is an organization that promotes awareness of kidney disease. We want to empower, we want to educate, we want to have advocacy programs so that more people are aware of kidney disease and all that goes along with kidney disease. And we also want to empower people to run their own foundations and to empower others to know more about kidney disease and learn everything about it. IFKF-WKA also joins hands with International Society of Nephrology in observing World Kidney Day. And World Kidney Day is something that is observed and celebrated all over the world. And we have to say that our founding father, Dr. Joel Koppel, is one of the people who instigated and started this movement of the World Kidney Day. I would also very quickly like our Dina, can you say a couple of words? She's our secretary. Dina, will you say a couple of words?
Hello, it's a pleasure to be with you today. And it's always a pleasure for the IFKF to have joint meetings with other communities and other societies. And actually, this topic is one of the very important topics. And this topic actually needs a lot of work and a lot of advocacy, because in many areas, and even in my country and in many other countries, this is a neglected topic that have a serious complications and serious impact later on. And many of the physicians and of the obstetricians are not aware of the consequences that can lead to chronic kidney disease or end-stage kidney disease later on. So actually, this needs a lot of awareness for the patients, for the physicians, for the internists, for nephrologists, and for everyone. So thank you so much for choosing this topic. And I'm sure that we will have a very interesting webinar today. Thanks again.
Thank you, Dana. So I will get into this right away. I welcome all our delegates who are here today. I welcome our speakers. Shanthi Mohan is a person who is an IFKF member, IFKF-WKA member, and she joined us recently. She's a person who's highly motivated. She knows what kidney disease is, and she knows all about gestosis, which is a serious disorder affecting motherhood. She has been through, a ringer in her life after having given birth, and she's a fighter. She's been on CAPD for 20 years. She's got a long list of, fantastic achievements in her name. She's also an entrepreneur, and we have to say hats off to her for organizing this. We, of course, are very happy to have Dr. Bhavna Mehta with us. She's a world-famous gynecologist. She has experience of 26 years in gynecology, and she is a specialist in diagnosing, treating, and helping in preventing diseases of women, particularly those distressing their reproductive system. So, Dr. Bhavna, we are very, very grateful to have you with us. You have a long biodata and CV. You've won several awards, so we're very, very grateful to you, and we're very privileged to have you here. We have not yet got Dr. Jeyam Kannan, who will be joining us soon. And she is a person who is a renowned gynecologist and obstetrician in Chennai and is currently practicing in Chennai. She is a person who knows a lot about gestosis, and she will also be talking to us about this. And of course, Dr. Georgi Abraham, who's a nephrologist, who is part of Tanker Foundation and our IFKF-WKA member. He's the person who got Tanker Foundation into IFKF-WKA. Dr. Georgi's list is too long for me to read. So he is a world-famous nephrologist. He is the father of CAPD, and his patient is Shanthi Mohan. He brought CAPD into India after um, learning under the famous Dr. Oriopolis, Dimitrios Oriopolis in Canada, who was the father of CAPD. So, of course, Dr. Georgi has been involved with transplants and so many things, and he treats patients from varied backgrounds. And because of him, we started this kidney foundation that helps the underprivileged. And so I welcome all of you here today. We're privileged to have you, Dr. Georgi and Shanthi and Dr. Bhavna. And I would like Shanthi to start with her story.
It's actually a pleasure to be here and a privilege for me to be able to address such dignified people. Like Lata was telling, Dr. Georgi is the father of bringing in peritoneal dialysis to India, and he's a father to most of us patients. That's how he takes care of us too. I'll just talk a little about myself. I was just a normal
Shall we do the screen sharing, Shanthi? Sorry to interrupt you.
Yeah, you could.
Okay, yeah.
You could do that.
We're waiting for Kausi to get the screen going.
So while Kaushi ma'am is trying, I'll just, start off. I was a perfectly normal woman, energetic, lively, and active. I graduated with an MBA in 1993, and I didn't have any health problems till I got pregnant. Ma'am, you could, Kaushi ma'am,
to the next slide.
Yeah, fourth slide. Yeah, this is fine. And I was married in 1997. And in 1999, I gave birth to Anjana. Like every mother, it was the most beautiful moment for me in my life too. We'll talk about how it all began for me. We could go to the next slide, ma'am. So in the 7th month of my pregnancy, my albumin was found to be 4+, and yet my BP was normal. When we had doubts, my gynecologist had doubts about this, we checked with another equipment and we found the BP to be at 240 by 160. And the gynecologist was really perturbed, and she advised rest till delivery and also to consult a nephrologist, who said my kidneys were in a bad shape, and he prescribed medicines which caused loose motions by that evening. So I was asked to stop all medication and consult my gynecologist, who just washed her hands off me. And she asked me to just find another gynecologist to help with my childbirth. I was here totally lost. And I asked my GP, who was been taking care of me from when I was a little girl, to go to Dr. Shanta at SMF. She took me in a very precarious situation under her wings and delivered my baby and saved me too. So what happened was I had a preterm baby, delivered a month earlier, and Dr. Shanta advised a specialist check for BP to be controlled and monitored. The hypertension specialist prescribed medications to keep it in control. But what I did was I was very undisciplined in my medical intake. And this went on till my baby was 3 years old and I was diagnosed with chronic renal failure. So the mistakes I had made were I didn't go to a good gynecologist. I was very ignorant about health, and I did not watch my weight increase during pregnancy from 40 to 62 kgs. I did not exercise regularly. I kept to myself. I was in solitude and I did not keep myself stress-free. I was very stressed and I did not, follow the medication. And I felt very guilty to indulge, with a newborn baby. I felt I should not indulge in myself. And then headaches following by, Crocin poppins. I started having a lot of symptoms like nausea, fatigue, proteinuria. I had severe itching and rashes on my skin. And we did tests which revealed severe anemia, high creatinine and urea levels, and it led to the diagnosis of chronic renal failure. Initially, I was on hemodialysis, and then I was initiated on peritoneal dialysis. Like slowly, it dawned on me what my life was going to be like in the days to come. I was actually in total denial. My baby was only 3, and how could I get sick? I kept wondering what happened to bring me to my life to a standstill like so. Life did become like a big question mark. But realization did set in slowly, and it did tell me that the situation can't be reversed or changed. I was challenged to accept the fact. It was a slow process, many admissions into ICU, and many challenges later. Today, I turn back to see 21 years have gone by. There were a list of challenges, when I was in these 21 years. Like I had a renal transplant, and because due to a tuberculosis infection within 24 hours of transplant, the transplanted kidney had to be removed. And I was on tuberculosis treatment for 1.5 years. Meanwhile, I was back on PD after 2 months of my transplant. Then slowly I started having high IPTH levels, which triggers bones to release more calcium than normal and leading to low bone strength, making them very weak and brittle. Sorry. And I was on hemodialysis for 6 weeks. The thing is, I also had a parathyroidectomy. Sorry about that. And this was to control the IPTH levels, which were going really bad. It was debilitating me and disfiguring my bones and my gait. Everything was getting bad. So after this parathyroidectomy, I started becoming more active and agile. My pain started lowering considerably. Having been on dialysis for many years, I started developing calcification in my peritoneal membrane, which started affecting the ultrafiltration. And this, I had to go through hemodialysis during that time in 2019. This was again a very difficult period because I started becoming malnourished. I had low blood pressure, low appetite. I was treated with albumin infusion. And yet again, a very difficult period, but Dr. Georgi sailed me out. I had various challenges, and I'm sure, like most of you, I would agree that 20 years would not have been uneventful. Yes, there were many events and each a challenge on its own. Many visits to the ICU for the peritonitis, challenges of drain blockages. I had high blood pressure challenges. Every season would bring us, new challenges. Nutrition was a big challenge, to be able to plan a proper nutrition. Apart from these, there were also other things like emotional security was a challenge for me, financial security, and, the whole family dynamics, family equations also change when one is sick. So this fight against my disease, fortunately for me, was not a lone struggle. My family and my doctors have always been my pillars of strength, and they've always been by my side. My doctors, Dr. Georgi Abraham and Dr. Millie Matthews, they're so proud about me, and they are the torchbearers to my now glorious life. Like, why would I say it is glorious? Because that is how much, like they've supported me. Next slide, ma'am. So I've come to realize that we all fail at some time or the other, or it's something or the other, but that's okay, right? But what is not okay is not trying. After 21 years, I realized I failed to take care of my health. Now I can accept that. Today, it is not about achieving something because I didn't even have an aim. I just share my experiences because such stories of endurance can make one feel and realize how faith can change lives in miraculous ways. These years, I learned a lot about myself and what I wanted in life. I realized there's a purpose I lived so far. I explored and found myself. Today, I see everything I dreamt of coming to me. Next slide, ma'am. So what did I do? See, I understood my situation, what it was, and I accepted it. I know it couldn't be reversed, so what should I do with whatever I was given? I maintained a positive self-image, and I erased all kinds of self-pity, which initially we all do tend to have. One thing that I made it a habit was to exercise and be independent as much as possible. I changed my diet routine, with the help of my doctors and my nutritionist, and did something, that really worked out well for me. I had a vision for myself, and I believe my journey does not end here. It will keep going on. At 55, I've initiated DIPA, Dialysis Patient Association, and my own business. I had the grit, the courage to push through, no matter what the obstacles were, to make it thus far, because I think it's worth it. No matter what happened to me in the past or what's going to happen to me right now, what is happening right now, what's going to happen to me, it can't keep me from having an amazingly good future because I want it. With perseverance and a faith, I will live my dreams. I was told many times that was not good enough. Now I tell people, not only am I good enough, I think I'm more than enough. So we started DIPA. DIPA's goal is to empower patients like me. I want to build a community and drive forward a momentum for kidney failure patients in Tamil Nadu. We want to form a community to help people deal with kidney-related challenges and improve their quality of life with longevity. Organize sessions, such as these on preventing lifestyle-induced diseases with timely interventions, increase awareness on kidney health and changes in lifestyle. So why do we need a community like, whether it's IFKF or Tanker or any of these communities? It's to bring people, with similar backgrounds together. The community gives us a sense of belonging. We all have a sense of wanting to be connected and share personal experiences. This is what a community like this can do. We can advocate and support each other in the fight to overcome adversities. We all feel, we're a part of something big and connect, and we can know that we can reach our goals. This is an opportunity to learn new perspectives from, professionals like doctors and feel empowered and supported by others. This contributes to a common goal and build relationships. So how I take the community support forward is through counseling. And every day I talk to a lot of patients and we give them, encouragement and hope that we can have a stable life. It can be achieved on PD. Because personally, I advocate PD because I think it has given me a wonderful life. I listen to a lot of patients and most importantly, their caregivers also, because they're an ignored lot. We want to talk to them also because they're the ones who support the patients in many ways. We guide people to make them aware of kidney health and counseling patients to be initiated on PD. And those who are already on PD, we give them help. I have done many home visits to the underprivileged sections where they are on PD and they don't know how to handle the entire process. So I go and train them on PD, teach them how to keep their surroundings clean and hygienic, and teach them, things about diet and how they can manage their whole lifestyle. Next slide, ma'am. So in India, for kidney community support, we have Kidney Warriors, we have Tanker Foundation, we have IFKF, which is bringing all of us together, Sapiens, Triumph by Mohan Foundation, and the Indian Renal Foundation of Gujarat, and many more. So here I would just like to bring to the notice like how the government is helping. people like me in Chennai, in Tamil Nadu, they have a scheme known as the Makkal Tedi Marthuvam scheme, where the PD bags are being delivered to home to patients all over Tamil Nadu. They also receive constant BP checks, and blood routines are done free of charge at the government hospital for every kidney failure patient. We're also covered by the Tamil Nadu health insurance scheme. And this is such a wonderful initiative, and it's very beneficial both for patients and the government. The government can save many man-hours on PD compared to human hemodialysis. So because every PD patient makes only one visit to the hospital every month, but whereas on hemodialysis, like every 2 days, they need to, keep resources for a patient. So the government can actually initiate many more features into the scheme, which would be actually mutually beneficial for patients and for the government. Next slide, ma'am. So I'm done with this. I think we can move on to Dr. Bhavna's presentation, where she'll give us the perspective from a professional's point of view. Thank you so much for listening, all of you. Thank you. Thank you, sir.
Thank you so much, Shanthi. I think that was wonderful. It's a story of true grit and courage, and a big inspiration to all of us. And definitely IFKF-WKA is going to benefit having you as a member and as our advocate for awareness of kidney disease. So thank you so much. I now welcome Dr. Bhavna Mehta. Kausi, can we get her, get doctor's slide going? As I said, Dr. Bhavna is a famous gynecologist, and she has experience of 26 years in the field of gynecology. She's a specialist in diagnosing, treating, and helping in preventing disease of women, particularly those distressing their reproductive system.
So, good evening, one and all. I take this opportunity while Kaushalya gets my slides ready to talk a few words about Mrs. Shanthi RajMohan. And Shanthi is faced challenges in life, but she has taken the challenges and makes it a smile throughout everybody's life now. And I know Shanthi since my school days. And she's the one who lights up our group, a school group, and takes things forward. And I think on a personal front, we have learned a lot from her. So yeah, a big clap for you, Shanthi. Proud of you.
Sorry, give me a minute. I just lost 1 second.
Can we have the next one, please?
Can you see it now? Yeah.
Yes.
Yeah. So today's topic, gestosis, is the functional multi-organ systemic complication of pregnancy connected with the development of the fertilized ovum and characterized by a lot of symptoms. As a rule, after childbirth or an abortion, almost all the symptoms of gestosis are abated or stopped. Next one, please. Now, what are the risk factors of gestosis? It's primigravida. Primigravida meaning the first pregnancy, either too young or too old. Family history of hypertension, preeclampsia, placental abnormalities, where there is hyperplacentosis, meaning in molar pregnancies, twins, and diabetes. Poor placentation, placental ischemia, genetic disorders, immunological phenomenon, pre-existing vascular disease, new paternity, and thrombophilias. Now, what do you call as a gestational hypertension? When any BP is recorded, it should be recorded in a pregnant woman in a sitting position or in the left lateral position, but a sitting position in the clinic is ideal. So the normal BP is somewhere around 110 to 120 systolic and 70 to 80 diastolic. Sustained systolic blood, no, previous slide please. A sustained systolic blood pressure at or above 140 millimeters mercury or a diastolic above 90 millimeter mercury. Increase in BP must be present on at least 2 separate occasions, 6 hours or more apart. Hypertension in late pregnancy more than 20 weeks, in the absence of other findings, is suggestive of gestational hypertension. If the BP returns normal to baseline by 12 weeks after delivery, then there is a diagnosis of transient hypertension of pregnancy. Next one, please. The incidence of gestational hypertension is 5 to 10% in pregnancies that are beyond first trimester, and the increased incidence of up to 30% in multiple gestation. There is a 15 to 25% of women initially diagnosed with gestational hypertension who go on to develop preeclampsia. The earlier onset of gestational hypertension is more likely to progress to preeclampsia. Next. Now there are 3 forms of high blood pressure, which is mild, moderate, and severe. And the findings of systolic, mild is in systolic is 140 to 149, diastolic 90 to 99. The moderate hypertension of 150 to 159 and diastolic of 100 to 109. And in severe cases, more than 160 and diastolic of 110. To understand the pathophysiology, we first need to understand the normal physiology of changes in pregnancy. So as you know, in pregnancy, there are hormonal changes where there is increased level of estrogen and progesterone. This leads to circulatory changes of increased vasodilation, cardiovascular changes of increased heart rate and cardiac output. A decreased blood pressure is equal to a increased cardiac output and decrease in total peripheral resistance. The next one. Next slide, please. So where does it all begin in pregnancy? It all begins from the placenta. The next one. In the placenta, we have these endovascular cytotrophoblasts, which invade the spiral arterioles, and this causes a vascular remodeling, and the spiral arterioles become a loose vascular channel where there is increased blood flow flowing through the placenta. What happens in hypertension in pregnancy is there is no infiltration of the cytotrophoblasts into the spiral arterioles, and as a result, there is narrowing of the blood flow and poorly perfused placenta, resulting in intrauterine growth restriction of the fetus, if ignored, into fetal death. And this also releases pro-inflammatory proteins, which causes a lot of damage as we go further to see. Now, this is another interesting pictographical image of preeclampsia pathology. The purple one is the placenta, and there is hypoperfusion because the arteries are not having enough blood flow. And there, this is the pictorial systemic vasoconstriction and endothelial dysfunction, which causes hypertension and end organ failure. And the liver is shouting for help because it's damaged, not literally, but help stands for hemolysis, elevated liver enzymes, low platelets, and your kidneys are spouting with proteins causing proteinuria. What is the curative treatment out here is delivery. The next slide, please. Next one. I am going to deal more with renal abnormalities in pregnancy in preeclampsia, as the forum here is on kidneys. So the series of unique pathological changes here, you have diffuse glomerular endotheliosis, swelling and vacuolization of the endothelial cells, the capillary lumen occlusion, and enlarged glomeruli. Next one. Next one. So here again is the pictographical demonstration of the renal abnormalities in pregnancy, where you have decreased glomerular filtration rate. There is a decreased prostacyclin production. decreased renin-aldosterone release, an increased uric acid reabsorption, an increased sodium reabsorption, decreased renal blood flow, proteinuria, and endotheliosis. Next, please. So why decreased glomerular filtration? It is because of the decrease in the renal blood flow, vasoconstriction, the plasma volume loss, and decreased cardiac output. The other factors are the impaired placental production of vasodilator, relaxin, impaired renal prostacyclin or nitric oxide production. Next one. The plasma renin and aldosterone are reduced in preeclampsia, correlating inversely with the severity of the disorder. Next. I'm summing up the clinical features of the preeclampsia once again. The primary manifestation is hypertension. With proteinuria comes the renal involvement, significant proteinuria, a dipstick positive confirmed by spot urine protein creatinine ratio of more than 30 milligrams, acute kidney injury, serum or plasma creatinine more than 90 millimoles, oliguria, a hematologic involvement of thrombocytopenia or low platelets, hemolysis, and DIC, a liver involvement or raised serum transaminases, severe epigastric or right upper quadrant pain. As they come to the OP, they would come with severe epigastric or right upper quadrant pain, a neurologic involvement of convulsions, which is eclampsia, hyperreflexia with sustained clonus, severe headache with hyperreflexia, persistent visual disturbances, cerebrovascular accidents like stroke. Other major features include pulmonary edema, fetal growth restriction, and placental abruption. Next. Now, what do we do to predict or prevent hypertension in pregnancy? There is no single test that can be reliable in predicting the development of preeclampsia because of multiple risk factors present. The measurements of angiogenic factors in blood or urine seems a promising approach, but these tests require further study and are not part of usual clinical practice at present. Next, please. How do you prevent? There is aspirin, which is time and tested, begins at 12 to 14 weeks of gestation. We discontinue aspirin 10 days before the expected delivery. Women who have already developed preeclampsia will not benefit from aspirin in preventing progression to more severe disease. Oral calcium supplementation appears to halve the risk of preeclampsia in women at high risk and in communities with low dietary calcium levels. Nutritional supplements like magnesium, folic acid, fish oils, antioxidants, etc. are not effective in preventing preeclampsia. Next, please. Anticoagulation is not recommended for reducing the risk of preeclampsia. Maternal obesity is associated with increased risk of preeclampsia. Antihypertensive drugs do not reduce the risk of preeclampsia. Currently, the maternal serum levels of PAP-A in the first trimester of pregnancy are decreased in pregnancies with fetal trisomies or called Downs, that is T21, 18, and 17. In pregnancies that develop preeclampsia compared to unaffected pregnancies, it's found that the maternal serum PAP-A is decreased during the first trimester, not significantly different in the second, and increased in the early third trimester. So this is now becoming a tool in the first 12 to 14 weeks, where we do a first trimester screening for Down syndrome. We also get a chance to screen women for preeclampsia by PAP-A tests. Next one, please. Now, what is proteinuria? Proteinuria is a sign of preeclampsia, which is defined as more than 300 milligrams of protein in a 24-hour urine collection, or a urine protein creatinine ratio of more than 0.3, or persistent or more 30 milligrams per deciliter protein in a two urine samples collected 4 to 6 hours apart. Proteinuria is also a valuable sign of severity and a value of 5 grams in 24 hours is one of the criteria to classify preeclampsia as severe. The 24-hour urine collection for protein is the gold standard in the diagnosis. Next, please. So usually when the woman walks into the clinic, every time she walks in, if it is weekly, yes, or it's twice a week, depending on the severity of the preeclampsia or the hypertension, we always do a urine dipstick test, and that the results are, if it is a 1+ urine, then we know it is 0.3 grams of protein, 2+ is 1 gram of protein, and 3+ is 3 grams. So that gives us the severity of the preeclampsia in itself. Next one, please. Now, why do we screen for anti-phospholipid antibodies? Because that is also a precursor of hypertension or preeclampsia. Prophylaxis with both low-dose aspirin and prophylactic dose of heparin starting at the end of the first trimester or 12 weeks, continuing throughout pregnancy, has known to decrease the rate of pregnancy complications and improve pregnancy outcomes in patients with antiphospholipid syndrome. But screening the general population is not yet done. The ACOG recommends taking a detailed medical history to assess a patient's risk for developing preeclampsia, along with the role of laboratory and imaging testing. Next, please. Blood pressure elevation. A persistent elevation in blood pressure is the hallmark. So as I had mentioned before, in the pregnant woman, the lateral recumbent values are always lower than in the sitting position. So it is very, very important that whenever a pregnant woman walks in, we need to check her blood pressure by making her sit down and not by lying down. Why? Because this delays proper diagnosis. If the patient is lying down and you take her BP, it is going to delay a proper diagnosis and treatment. To avoid these errors, the blood pressure at each pregnant visit should be taken with the patient in the sitting position. The official recommendation of the ACOG is to use the Korotkov 5 sound, the point of disappearance of the sound, as the marker of diastolic blood pressure. We have a lot of provocative pressure tests to predict, which are biophysical tests such as cold pressure test, isometric hand grip exercise, Gant's rollover tests, etc. But then the predictive value here is very poor, and so hence are not done nowadays. Next. The uterine artery Doppler velocimetry. This is the one which is helping us out dealing with our preeclampsia and hypertensive patients. At 22 to 24 weeks is predictive, and it is the best available tool for early detection of preeclampsia of placental origin. An abnormal uterine artery velocimetry is characterized by the pulsatility index, which is about the 95th percentile, or the presence of early diastolic notching. Next one, please. So this is how the uterine artery Doppler velocimetry looks on the screens of the ultrasound machine. And this slide is just a representation of what it looks like. Next one, please. So in conclusion, I would like to summarize the key points and importance of prevention. In prevention is a skill for a healthy outcome. The key points include early identification, a healthy lifestyle of choices, regular prenatal care, and importance of medical intervention when needed. Self-monitoring and a strong support system also play vital roles in reducing risks and ensuring a successful pregnancy. Prioritizing prevention is the cornerstone of a healthy pregnancy when dealing with hypertension. Next. Supporting pregnant individuals, like Shanthi was saying, encourage family and community support. Emotional support from family and friends is crucial during pregnancy, especially when dealing with medical conditions like hypertension and preeclampsia. Encourage open communication and understanding within your support network. Highlight the emotional aspect. Dealing with hypertension during pregnancy can be emotionally challenging. Share resources for mental health and stress management. to help individuals cope with the added stress and uncertainty. Next. Thank you for your attention. The other topics, treatment and the pre-eclampsia, eclampsia will be dealt by the next speaker, Dr. Jeyam Kannan.
Thank you so much, Dr. Bhavna Mehta. I think I'm a layperson, but I've understood so much from what you spoke today. So thank you very, very much. I welcome Dr. Jeyam Kannan. She is a renowned gynecologist and obstetrician. And we are so thankful and privileged to have you here with us, Doctor. Would you like us to screen share with you? Thank you so much.
Yes, please. Yes, please.
Okay.
Please.
So I'll make you a co-host and you can just screen share.
Yeah.
Okay. Thank you, Doctor.
Bhavna has made things very clear and she has discussed both medical and non-medical points in her history. While the skin is being shared, let me start saying, Shanthi knows my experience goes to 5 decades plus. My first patient delivered was in 1970 on 17th January. That means 54 years I am in practice. That is in a primary health center where I sat for 3 days in the guest house nearer to the primary health center, rural guest house. You know how it would have been 50 years ago. And I had delivered her 7 years after marriage, forceps delivery, and the child is fine at Germany. Now to give you history about eclampsia, pre-eclampsia, my mind is full of all those things. I would like to say 1995, she was a 7th pregnancy, no live child. Don't know what was the reason. When I saw her, it is said to be abled. When I saw her in 1995, I found her to have blood pressure and proteinuria. You know how much proteinuria? 5 grams. Yeah, admit.
Yes, Doctor, we have enabled screen sharing for you.
No, the thing it says disabled.
Oh, oru nimisham.
It still says disabled.
Can I, if you
Yeah,
can...
yeah, now I am getting it. Now I
Yeah.
am getting it. I am there.
Oh,
Okay, I am there. Is my screen visible?
yes, it is.
Yes.
Thank you.
Right. Mercury spirometer is the gold standard. Okay. That is one thing which I still believe. Whenever I have a high blood pressure patient, they bring the big one and I check it by myself every visit. So this pregnancy, 34 years, 5 grams protein by 6 months. Now we talk about 200 milligram, 300 milligram, 400 milligram. I did not know what to do. And she went up to 7 grams. So from Trichy hospital, by the time I have started a hospital in Chennai, so I shifted her to Chennai hospital. One nurse was kept with her for hourly monitoring of the blood pressure and everyday monitoring of her urine output and the baby. At that time, ultrasound was not too much. Dopplers were not too much, but still we somehow managed. In between, I went to Japan for a conference. So my colleague used to call and say, Jeyam, by this thing, proteinuria is 7 grams. You are just sleeping over the patient. You are going to bury her. I said, no. Now that she has accepted for 2 months with the 5 grams, she will accept 7 grams for another 1 month. So 20 days she stayed in the hospital. At last, by 245 days, she delivered. So everybody was so happy that she is hugging a baby and going home. But what happened? 30 days later, she comes back to the hospital. Incoherent speech. Doesn't recognize any staff. And stammering gait. very high blood pressure in spite of the fact she is on the tablet. And because she was having some visual problem, I sent her to Shankara Nethralaya. They found some unusual findings in the eye, which they have never seen before, and they could not correlate to any particular disease. They took the case for a research work. And somehow we all managed her on hypertension. She went home. You see, about 7, 8 years later, she landed with, because she was on a good urologist care, shifted to dialysis. By 2008, she had to go for a renal transplant. She had only one child, going okay in life. Now I know what her problem was. 1996, the clinical radiological entity initially described this as PREC, posterior reversible encephalopathy. That is, the back part of the brain undergoes blood circulation deficiency, but it is a reversible encephalopathy. 1995, nobody knew the diagnosis. Somehow we managed. Now, press is a big problem and it is being described very much, and it is commonly this thing which manifests with confusion state, convergence, and acute blindness. My patient had confusional state, blindness. She was not able to, she didn't throw a fit, but she was about to throw a fit, and I was able to somehow manage her so that she was going on well. So after 1996, press has become a big entity, and I have seen many cases of press and I am managing it. That is what I wanted to add to what Bhavna has talked about. Yes, she has talked about albumin, blood count, and all the liver enzymes, bilirubin, serum creatinine, and serum uric acid, which we have to look at in this case. Now, the blood pressure examination is very specific. With International Society of Hypertension, how you make the patient sit, how you have the chair which can be positioned according to the patient, how you should record in both hands simultaneously, minimum 3 times, and take an average of all the 6 blood pressures. Okay, this is what is a blood pressure record in a pregnant woman every visit in a hospital. If all the more must by a doctor if she is found to have a hypertension. And ultrasound, what we look for apart from the baby, for these problems of complications, we have to look at the liver for hematoma and enlargement, kidneys for signs of renal disease, and the parenchyma of the mother. Up to nearly 30 weeks, we can scan the kidneys. But even otherwise, experts can just have the kidney scan, even if the baby is 34 weeks. When they also have to look for fluid in the chest, that is called pleural effusion, and fluid in the abdomen, apart from the baby, is called ascites. These are all the worsening signs of preeclampsia. Okay. At each visit of the patient coded as hypertension, this file history has to be occurred. Are you having any specific symptoms? She says, I am somehow unusual. That is a symptom. Do you have any difficulty? Nowadays, I don't ask for visual disturbances. I ask them, are you able to read your cell phone with the same letter which you are having? Or have you increased the font of the cell phone? This is because in 2001, I had a lawyer who said, Madam, I'm somehow finding it difficult to use the cell phone. I'm not able to see it properly. That was the way which made me realize visual disturbances in the present era should be managed with looking at the cell phone. If she has changed the font, if she is not able to read the cell phone, or she takes a phone like this, that means she has got visual disturbance. Headache, everybody knows. Pain in the right side and increase in the fluid in the edemas like that. Now, 2017, the American Association has given a very good wake-up call. Don't be waiting up to 140, 90 blood pressure. You start be careful even at 130, 80 blood pressure. This wake-up call has been given, and the government of India, in Indian situations, is taking anything 30 plus from the base level. Because many women in India have got 90/60 blood pressure. I am an example. In my first pregnancy and second pregnancy, I had only 90/60 blood pressure. And it went down to 80/60, for which my professor did not bother. This 90 blood pressure, 30 plus is 120. So now Government of India has made it very clear in all government institutions. If in the first 8 weeks or 10 weeks you have recorded 190/60, and by 24 weeks you are recording 120/80, that means you have to take her as a hypertensive disorder. And if the nurse or the primary health center doctor has not noticed and the patient lands in complications, the doctor and the nurse is being suspended in Tamil Nadu. If she goes in for any complication, now the doctor and nurse are suspended by Lakshya guidance of Government of India. And it is very vehemently practiced in Tamil Nadu because the second commonest cause of maternal death is hypertensive disorders in pregnancy. This 90/60 has to be taken, and 120/80 is one thing which everybody has to be worried, not even 130/80. 130/80 is for the American heart, but for us, it is 30 plus in Indian situation. Now, apart from this, we also have what is called Gestosis scores. Gestosis is association. No, well, Tamil Nadu, India has made out scores. That is, who are all the patients whom you should be very careful? Anybody who is conceiving after 4 or 5 years after marriage, 35 years, this lady, or she had 2 or 3 pregnancy losses, she has conceived after treatment by an infertility specialist. She has a family history of blood pressure. Her sister, that is called sore oral history, had blood pressure. Her brother has blood pressure. Like this, we have got 16 points on which the Gestosis score is taken. Any score more than 3, the obstetrician has to be careful in preventing pre-eclampsia, because now we say pre-eclampsia itself can be prevented if only the patient cooperates and the doctor is able to be very clear that she manages the case on her own. In group practices, there may be a junior doctor seeing the patient, and once in 2 months the senior doctor sees. No, in hypertensive disorders in pregnancy, the senior obstetrician should see the patient every 15 days. That is what is the demand now. Okay. Now, if the patient, can she be treated as outpatient, or if you are recorded 160, 100, you should keep her in the hospital for days together, as I have kept her for 20 days. Yes, if the patient has severe features, you have to hospitalize. If the patient has to take 2 hours to travel to the hospital, if she is not able to come within 10 minutes, if she is not close to the hospital, you have to admit. If she can measure her blood pressure daily, nowadays, because every patient can use the monitor and measure the blood pressure. Yes, she has to every day write all the 5 danger signs which I mentioned in the earlier one. If she is able to record it, and if she is able to come to the OP at least once a week, she can be at home. Am I practicing? Yes. Right now I have got about 5 or 6 patients on labetalol, antihypertensive drugs, 8 tablets a day with nifedipine, 3 tablets a day. Because the patient can send every day morning her symptoms and her blood pressure record. So if she has any of this problem, she has to immediately report. And if a patient is well, she need not be educated. At least she can record and send it to us. If she blindly follows the doctor's advice, yes, she can be at home. She need not come to the hospital before and get admitted before 37 weeks. Okay. Now, if the woman is before 34 weeks, we have to see that the baby's lung mature nicely. That is, Government of India throughout the world is advising antenatal corticosteroids. All of the Kidney Foundation people know well, steroids are to be very carefully given in any patient expected to have renal complication. Yes, in cases where we can measure appropriately in order to save the baby, because nowadays we are not having more than 2 babies maximum. Now it is only Tamil Nadu fertility rate is 1.3. That means for every 10 couple, we have got 13 babies. 7 couple go with 1 baby. So if these things are carefully monitored, antenatal dexamethasone can be given. Now, blood pressure medicines. Do we need to keep the blood pressure very tight, less than 130/80? Or what they say, we can just allow it to be little 140/90. There was a trial done called tight control of blood pressure, CHIPS trial, in chronic hypertensive pregnancy study. They found if you are tightly controlling 120/80 as per Indian standard, you have a fairly an average baby, but little less in weight, 2.3 to 2.4 kg. But if you allow the baby to be at 140/90, 130/90, your baby is little better. So these are all things which require good observation. What Jeyam Kannan is doing, I am allowing 130/90 as the base blood pressure. The drugs, all of you know well, all the antihypertensives are known to all the people in the Kidney Foundation. Whereas in pregnancy, we always give only labetalol as the first drug of choice. In 1995, I did not have a labetalol. I got to go and search for alpha-methyl dopa and give to the patient nearly about 6 to 8 tablets to start with, and went up to 300 milligrams, 3000 milligrams. I went about giving 12 tablets a day. Nowadays, alpha-methyl dopa is not so much available in India. We start with labetalol. How many tablets we can give? 24 tablets. But doctors are scared to give more than 4 tablets. I give up to 12 tablets in Indian scenario. Outpatient, you can give. The second drug is nifedipine. This is all which helps in blood pressure control. How many tablets we can give? 12 tablets. Giving 2 tablets itself is doctors are worried, because we find it very difficult to drill in the minds of our doctors such a high dose of tablets. But I go up to 6 tablets. I have had patients with 12 tablets of labetalol, 6 tablets, so that they were able to continue the pregnancy for about, from the time of diagnosis of high blood pressure, for about 50 to 75 days. How much we have to spend time, you see? Right. In these times, what we have to do is the baby's fetal movement has to be very clearly recorded by the patient. If she finds it difficult for about 12 hours, she has to come to the hospital. Then there is a test called non-stress test, which the doctor records with a computer aid. And of course, Doppler, these things are all to be done by the obstetrician. Right. Yes, madam. You started the drugs by 180 days. Yes, now the patient is 37 weeks. She has got only 20 days more to deliver. She is now 260 days. Do you still want to wait? No. If the patient has been able to go through up to 260 days, it's a great thing. If you want to still deliver vaginally, you can deliver if her conditions are favorable. If her conditions are not favorable, cesarean section is to be done for reasons that the patient is not ready to go for a normal vaginal delivery with giving drugs for induction of labor. That is the indication that is. Now, so far I have talked about preeclampsia. Now I come to the great terror disease of obstetrics, eclampsia. Eclampsia, yes, any patient throwing a fit makes the obstetrician go down in her blood pressure by 30 points. We really sweat, our pulse rate goes up, our blood pressure comes down. It happens 50% before delivery, 30% during delivery, and after delivery also up to 48 hours it occurs maximally, but nothing prevents eclampsia coming up to 42 days. That patient which I showed 1995 was not having this in efforts, but it is part of that only. It's just like an epilepsy. Any epileptic seizure in pregnancy is to be diagnosed as eclampsia unless proved otherwise. Right? This, who are all getting it? Any patient can get it, I will say. But nowadays, for theory's sake, anybody who is conceived after 35 years, first pregnancy, be it 16 years or 26 years or 36 years, if she had been treated for blood pressure, if she had been treated for any glomerular nephritis in younger age, AGN, which has been very much talked, and if there is a family history and she is coming for a 7th or 8th pregnancy, yes, these are all risk factors. Right, patient has come, she has thrown a fit at home, she is blocked. What do you do? As soon as a patient comes, don't ask for all the regular admission protocols, formalities in the patient. Take the patient immediately to a safe, dark, airy place and put her on a hard surface, not on a soft surface, and turn her to the left side and loosen all her clothes. And do not interpret if she has a seizure, just wait till the seizure settles down. By the time, another person should have done all the hospitalization. At that time, we have got two management. One is control the fits which are uncontrolled and see what duration of pregnancy you are seeing that. Because the treatment for eclampsia is deliver the baby. But nowadays, if she is 34 weeks and she has shown only one fit about 6 hours ago, after 6 hours she has not had a fix, can I wait for one more week? Because every day inside the uterus makes a baby better by 10%. If I keep for 10 days after delivery, after 34 weeks, that means the baby would have gained another 300 grams. Brain of the baby would have become better. So the fits are controlled. We give all the Maxelf and other things. Then, as I said, delivery is the hallmark for eclampsia. Find out whether the patient can deliver vaginally or you require a cesarean section, and find out whether the baby is immature, 34 weeks or anything. See if the fits are well controlled with Maxel. Can you wait for some more time? Yes, we have given purchase time like this up to 10 days in the patient. But however, an eclamptic patient cannot go home and she has to remain in the hospital only. At this time, any serum creatinine level of 1.1, yes, please be careful that this is a patient who will go in for chronic renal problems. Okay. And uric acid is also one thing which has been asked to be very clearly managed in these cases. And as Bhavna has said very clearly about the kidney problems, elevated uric acid and creatinine level or early warning signs of renal function, and this immediately, as soon as the patient is terminated, the patient should be handed over to the nephrologist for further proper management so that we avoid all the dialysis, we avoid transplant, because there are already so many transplants are waiting. When this can be a preventable problem, please prevent it appropriately with the treatment at the earliest stages. The aim of all this delivering is because we don't want the brain to go in for any problem. We don't want the baby to die with a blood clot in the uterus. Last week, we had a patient 75 days after the drug treatment. She came with a tightness in the abdomen at 35 weeks. Immediately, my daughter-in-law delivered her at a tertiary care center, and the placenta had about 250 grams of blood clot. The baby was 2.3 kg. All right. So this abruption, that is called the placenta getting separated, should be avoided. Nowadays, the eclampsia or hypertension is not only renal and nephrology problem, renal and cardiac, cerebral problem. Cardiac problems are more seen in hypertensive patients, and all these patients should be kept the diastolic less than 100, and the difference, the total mean blood pressure is 125. That means if it is 130, 90, put together is 220. So that means average blood pressure is 110. That is a safe blood pressure. Never to exceed 125. That means systolic and diastolic put together should never be more than 250 for not inviting any problems. So in these patients, eclampsia, all the investigation which Bhavna has said is being also done. Yes, we have to give the nursing care, we have to give the maxil, we have to give the obstetric management also. Yes, it is a hospital, or not every hospital is a tertiary care center. Like we don't have everything as Apollo or these hospitals like Kaveri, Mehta Nursing Home, or First Med Hospital like that. Or even this is Sundara Medical Foundation, which are all hospital which can care these patients. Hospital like mine, where I have 25 beds, I have 3 obstetricians. Myself, my daughter-in-law, and there is another obstetrician by name Priya Kannapan. We are 3 obstetricians with my daughter Priya Kannan, who is also into this field for the past 22 years. In spite of 4 people, I would never like to keep an eclamptic patient after initial management. I will have to transport the patient to these hospitals with the baby inside the uterus, carrying the baby with the mother, so that the midwife takes a patient to the hospital with all the records and hand over the patient so that she can have the cardiologist, nephrologist, neurophysician, and whatnot. Everybody with this is ICU for the mother, NICU, neonatal intensive care unit for the baby, and all facilities for any bleeding problem. These things are required for these patients. I won't even call centers single unit. Nowadays, we have the hi-fi maternity centers where they only take care of the deliveries. But these are not the hospitals for hypertensive disorders in pregnancy being managed. I had a patient in one of the big hi-fi maternity centers, like we have got a chain of maternity hospitals. The patient delivered, PPH, everything done. Suddenly her blood potassium level went up to 9. There was no hematologist or anybody available in that hospital. I immediately at 11 o'clock in the night took her to Apollo First Med, where she was managed. Within 2 hours, her potassium level was brought down and she escaped a cardiac injury. And till today, 5 years, her heart is quite all right. Even though you are able to manage her, but we leave a scar in the heart which could not have been otherwise managed. Okay, during delivery, the doctor, junior doctor, the nurse, and preferably the senior doctor should also be available then and there for this delivery. After delivery is the one which is very, very important, with Shanthi will accept. Okay, because immediately after the delivery, the patient remains in the hospital for 4 or 5 days and she has to be given the antihypertensive process. You can review after 6 to 8 weeks, but kindly hand over the patient to a nephrologist, cardiologist, or neurophysician, or a pulmonologist, depending on what problem the patient had during her delivery. I won't say everybody to go to nephrologist. If she had a lung problem, she should be seen by a pulmonologist after delivery. That is what is important. Like the patient who had only a blood clot and her blood pressure settled down. I can manage her even after delivery for years together, but not a patient like the one who had a press. She has been going only to a neurophysician and a urologist. Now she is with a urologist. So all the preeclampsia patients who have been given all this treatment must be given a proper care, and any patient who is not responding should be taken care of only in the tertiary care. So I think I have managed, I have put all my findings to you to the possible level that you can guide, because you have to guide any patients who this thing you come across and you meet doctors. Tell them, see, it is the second commonest cause of death throughout the world, more so in India. Please do not allow the child born to be a motherless child. Please allow the baby to hug the mother, in which case you be a little lenient in sending the patient to a tertiary care center. None of the patients whom I have sent to Sundara Medical Foundation, Apollo First Med are all not coming back to me. They take very sincerely the referral which I have done, and they come back to me with the baby first birthday, second birthday, even 54th birthday, I am seeing the patient. Thank you.
Thank you so much, doctor. Thank you.
So I
Thank
stop
you.
sharing the screen.
Thank you so much. I think that you explained everything so beautifully, and I can't imagine that you are as old as you make yourself out to be, because you look very young. And I now ask Dr. Georgi Abraham, renowned nephrologist, father of
Yes.
CAPD in India,
Yes.
to sum up and say a few words to all of us. So,
Sir,
Doctor,
unmute yourself, sir. Unmute yourself.
you'll have to unmute yourself, doctor. Press the...
That red button, please put it off.
Can I unmute him?
Yeah, if this thing, totally they have muted. I don't think the host has muted everybody.
He's okay.
No, we haven't.
Yeah. So, sir, please.
Doctor, please speak. We can't hear you. And you will have to increase the volume.
Probably you have not touched the F2 button. F1, F2. If you have put off F1 button, please put it out.
Sorry, doctor, we can't hear you.
Oh.
You want to exit and enter again?
I think there is some problem with his muting sound system, microphone.
Can't hear you, doctor. We cannot hear you. Doctor, can you unmute?
While he's trying to unmute, probably there is one other doctor, Srilata Hari, I could see. Then any other doctor?
Yes, Dr. Srilata Hari is here. And then we
Yeah.
have our IFKF-WKA members as well.
Yes, somebody can talk.
Doctor,
Yes, he is again muted himself.
yeah.
I think
He's
there's someone
admitted
helping.
himself now. Let's see.
Yes, he is coming by another one.
Yeah.
Cell phone, that is also good.
Yeah. Doctor, can you
Yeah,
unmute and
Yes,
speak?
sir. Your voice is audible.
Respected Dr. Jeyam and the colleagues, and it was a wonderful experience, personal experience you have shown, and we are all grateful to you for that. I just want to make a few comments. One is, I have my colleague Dr. Dina from Egypt sitting there, and other colleagues. Shanthi is an incredible woman with an incredible role model, and she has an incredible way of educating people. So I said 3 times incredible. And she has also engaged, educated, elevated, and empowered a lot of people regarding how to live with kidney disease as a lady and take things forward. And I just want to highlight a few things which I just came across in the American Journal of Kidney Disease, December issue. They were looking at the preeclamptic toxemia in the Jeysinger, which is a county in Philadelphia, and it is published in the December issue of the American Journal of Kidney Disease. So they looked at the hazard ratio, 95% confidence interval for adverse outcomes for preeclampsia cases in MASH cohort. Incident hypertension was the hazard ratio was 1.77, which was statistically significant. Incident eGFR of less than 60 ml per minute was a hazard ratio was 3.23 with p-value which was 0.001. Incident albuminuria, that is more than 300 milligram per gram of creatinine, was 3.6 hazard ratio, which was also statistically significant. And preeclampsia in subsequent pregnancy, after the first preeclampsia, it was very high. The hazard ratio was 24.56, and which was also statistically significant. I just wanted to add one more thing. Those who are going for assisted reproduction have probably more incidence of preeclampsia and hypertension. I may be wrong, but that is the information I got. So basically, I took care of 3 women who was transplanted. One is an MD, who was my student, and she became pregnant 20 years after transplantation. His father was the donor, and we had to do some changes, switch over in the medication, and she successfully delivered a baby boy, and which was normal delivery. And this is her second longest in the registry of transplant patient. The first longest is 270 months in Italy, and in India, in Chennai, we have 240 months. Recently, 1 month ago, I had a lupus young lady, 18 years after transplantation, and she wanted to become pregnant. We made the same switch in the medications, and she also delivered a baby. She had some hypertensive issues, but on minimal immunosuppression and control of blood pressure, she delivered a baby about 2 months ago, and that baby is also doing well. The third one is 8 years after transplantation, a young lady with IgA nephropathy. She had first pregnancy, which had spontaneous abortion, and the second pregnancy, we brought her here to Chennai, and she was taken care, and she had a cesarean section because the blood pressure was going at 32 weeks of pregnancy. So I have some unique individuals who got pregnant with their chronic kidney disease after transplantation. And I'm just thankful to Almighty God, and also the information given by Dr. Jeyam and also other people and Shanthi about how to take life in women who have chronic kidney disease and progress forward. That's all my comment, and thank you all for your wonderful presentation. And I submit before you when there is a chronic kidney disease patient or a kidney disease patient, what happens in the kidney is endotheliosis and podocyte damage. Podocytes are the food processor giving rise to proteinuria. So how to address that? Our 2 speakers have elegantly shown that, and I don't think that we need to hear anything more than that with their vast experience. And thank you so much.
So thank you so much, Dr. Georgi, for summing it up. I'm very grateful. On behalf of IFKF-WKA, I want to say thank you to Dr. Jeyam Kannan, Dr. Bhavna Mehta, to Shanthi RajMohan, and of course, Dr. Georgi for moderating. I would just like to ask Dina to say one more word before we close. We have run out of time, but I just want to say I'm so thankful, privileged, and grateful that you all joined. And Shanthi, you are an inspiration to all of us. And thank you for bringing on these wonderful doctors who have educated us in a very simple manner so that we understand. Dina, over to you very quickly to say thank you.
Thank you, Lata. And thank you for all the speakers. Thank you, Shanthi, so much for this very inspiring talk. And it's usually very important to hear the story from the patient perspective, which is sometimes totally different than from just applying what we know. But if we're looking from your side, which is different. Thank you so much, Professor Abraham, for being with us today. And it's really a pleasure meeting you today. And maybe it's just one point that I want to emphasize, that the preeclampsia or the problems going on with the preeclampsia, they are not cured or not end just with ending the pregnancy, but the process keeps on continuing. So it's very important to make sure that those patients are monitored and followed up. And I think that Shanthi has showed us clearly in a situation that the story does not end with the termination of the pregnancy, but sometimes it keeps on going, and we have to be aware of this. And this should be the message, our message for the nephrologists, internists, and the obstetricians who are following up those patients, that they need a nephrological counseling and monitoring even after the termination of pregnancy. Thank you so much, and thank you, Dr. Jaya, and thank you so much for all the lectures, and it was really a pleasure, and I've learned a lot from you today. Thank you.
So we look forward to
much.
seeing you at the next webinar, and which should be all going well next month. So thank you all once again, and
Thank you, ma'am.
thank you. We'll see you again soon.
Yeah.
Bye-bye.
I'll be seeing Shanthi in a big South Zone conference of nearly 1,200 obstetricians, in which I have requested her to say how the doctor's failure to follow up after delivery can result in problems. And she is going to stand as an example of the great success which the nephrologist can give, and with the perseverance of a woman, she can achieve a height.
Thank you so much. Thank you, Shanthi.
Thank
You're
you.
a torchbearer and you're our inspiration.
Yeah,
Thank you
I
very
have taken her as a torchbearer.
Yes.
Yeah, I know. Thank you, ma'am.
Thank you.
Thank you
Shanthi.
so
See you in the July.
Yeah, good night to all of you.
Bye-bye. Good night.
Thank you. Thank you. Bye. Thank you. Bye.